Welcome to the Summit PT Podcast, your guide to recovery, performance, and wellness. I'm Kevin Koska, a doctor of physical therapy, and this is Kelsey Sivley, a doctor of physical therapy, an orthopedic clinical specialist, and an expert in the pelvic floor. Pelvic therapy is an essential part of physical therapy, but can often be overlooked, whether it's postpartum, whether it's incontinence, whether it's pelvic pain, whether it's in the males, post-prostatectomy. It can be a very helpful therapy to regain function and get you back to normal life again. And today I'm excited to talk to Dr. Sivley about her specialty in the pelvic floor. And we've spoken to her in regards to the females, but now we want to do a special episode on males. And so what are some common diagnoses for males, and that has to do with the pelvic floor?
Well, I will start by saying men do have pelvic floors. I get that one a lot, not knowing that men have pelvic floors, just like women do. It sits between your sitting bones. It holds up our organs. For men, mostly the rectum and the bladder. But for them, a lot of the symptoms that they could potentially have would be after having prostate cancer and a radical prostatectomy. It impacts their continence a lot, their ability to urinate and having leakage, especially with exertional activities like jumping or pushing or lifting. Some of them have had trauma to their pelvis, to their pelvic floor, whether it be a fracture or a fall, impacting pelvic pain, or some of them chronic constipation as a result of all that muscle tension. Erectile dysfunction can be play a role with that as well. It just depends. Fecal urgency and incontinence. A lot of lumbar referrals sometimes giving testicular pain. So it varies, but a lot of common things like that.
I would assume patients always wait till it's been going on for 6 months or 12 months or 2 years. I assume that pelvic issues in males can often be overlooked, mostly because we're hard-headed and it could be embarrassing, or at least we think that it could be that. Can you go a little bit into why it's often overlooked? I'm just guessing on those two things, but since you're the expert, you may have a little bit more research behind that.
No, you're exactly right, Kevin. It's very commonly embarrassing to talk about any kind of leakage problems that a man might be having, or it feels emasculating for them, like they can't provide for their families if they are having to deal with something like this, if they can't lift or push or pull anymore. Because they have leakage, or they don't want to deal with it. If they don't talk about it, nobody can help. Some of them very commonly impacting their sexual function, and that's embarrassing to talk about, and that can affect relationships, and it's very emotional, and it's a lot to deal with. Let alone men who have had prostate cancer, that's sometimes very quickly moving. Oh, you got diagnosed, all of a sudden you're having surgery, and now you're seeing me in therapy. And you didn't get any time to really process that. It's a lot. So I feel like some of that is the reason why it's very often overlooked in a way. It's just not talked about enough.
Yeah, and hopefully this brings to light that there is something that can be done for the male. Can you go into what a typical session would look like? So we've kind of talked a little bit about the different diagnoses that they could have. And so let's say they make it into the clinic, they've seen the doctor, they hear this, they see it on social media and okay, I need to handle this, confront it and handle it once and for all. Right. What would a first session look like?
Well, I start with talking to the patient a lot and finding out what's going on, what kind of symptoms they're having. That's hard in its own right, just to even talk to me about it. And I try to help warm them up to it and assure them that some of these things are common, not normal, but common, and it is very treatable. And then we look at all their medical history. We look at any other aggravating or alleviating factors that might be playing a role. That way I can best figure out what's contributing to the symptoms. So I'll do a full comprehensive evaluation with exam, looking at their spine and their hips and their pelvis and how they're moving and pushing and pulling, what their breathing is like. And if they're up for it on the first day or maybe later, I will do a rectal examination to see how well they can contract and relax and then bulge down their muscles voluntarily, or if they have no clue what's going on in those muscles. It's different. It's similar to what I would do with a female pelvic floor evaluation. Just men have one hole that we have to look at, and we look at the perineum, and I try to explain everything in detail, and it helps a lot with figuring out what's going on, as well as any muscle tension they might have or motor control patterns that need to be worked on. And then we can get out into the clinic and really work on applying it functionally and seeing how they're moving and pushing and pulling and coordinating their core and their pelvic muscles and their breathing whenever they lift. It just depends. But we also look at the scar tissue if they have had surgeries. We look at any muscle tenderness that's going on. And we look at their abdomen as well, because just like I mentioned in the prior podcast, men can also have diastasis rectus abdominis and separation in their abdominal muscles. And that comes down to pressure management. That's everything. Learning how to push and pull and lift with good coordination of their core and their floor and their breathing without straining and adding a lot of pressure where it shouldn't be.
Yeah, so I mean, I know plenty of males that have diastasis recti. Mm-hmm. Fancy word. Can you explain a little bit what that is in layman's terms?
Yeah, the six-pack muscle, the rectus abdominis, right in between is the line called the linea alba. And when there's a lot of extra force and pressure going through that area with exertion, lifting and pushing and pulling, or even straining on the toilet, whatever it is, that pressure has to go somewhere, and over time it starts to separate those muscles and give us a big old dome or bulge or sometimes a deep ditch.
Is it still the two fingers in between there is the rule of thumb?
It is,
so to speak.
Yeah, if it's wider than the two fingers or deeper than two fingers, same thing, that's positive. And it could be anywhere along the line. It could be at the top, it could be at the umbilicus, it could be lower. It could be worse, depending on any surgeries that they might have had on the spine. That impacts the core as well, and in turn, the pelvic muscles. So even my guys who have had back surgery, that they could be impacted this way as well.
Yeah. So yeah, sorry to go down that rabbit hole, but I was just thinking of maybe 3 or 4 people that I actually know now that have that, and it's a pretty easy fix. You just have to do the right type of movements with it, and have the right knowledge. Otherwise, it can be dangerous, right? Your intestine can kind of come through that area and can be...
Yeah, it's common to get hernias as well,
yeah.
As a result of poor pressure management. Now, that's not for everyone. Some people just unluckily get a hernia, but a lot of times that extra pressure does add up and it can contribute to that risk. Or even hemorrhoids, that's a big one too. Straining all the time on the toilet. And the question is why? Is it dietary? If it is, I always send them to my friends at Nutrition World because I think they can help a lot with the supplement side of things and appropriately picking what they need best individually. But if it's musculoskeletal and they've had a lot of pelvic tension and tightness, they're working against a squeeze all the time to try to push out a bowel movement, and that adds up as well. And that extra blood pooling in that area, that can contribute to a lot of different things like that.
So sorry I went down that rabbit hole, but coming back to that first treatment and that evaluation, can you tell me a little bit? You're doing differential diagnosis. Is there something that might come in? Differential diagnosis is just, hey, you came in for this, and it's actually could be this, or this. It could be something else. Do you see that in this population of men?
Very commonly. I'm glad you brought that up because many of the patients I've seen come for pelvic floor therapy have complaints of potentially pelvic pain or testicular pain or penis pain, whatever it is. And I try to really make sure I'm ruling out the spine as it could be a contributor to that referred pattern. Just like maybe you've heard of the sciatica of pain shooting down your leg and it could be coming from your spine. The same thing can happen at the lower spine, contributing to referral into the testicles. If we clear up the spine, sometimes the testicular pain clears up with it. So I need to make sure that where they're having their symptoms is what is causing it, if that makes sense.
Absolutely.
Is it truly like musculoskeletal dysfunction at the pelvic floor, or is that dysfunction being driven by the nervous system and the spine in the first place? It just depends. I try to really make sure of why I'm treating what I'm treating, and my interventions apply towards whatever findings I had in my exam.
Absolutely. So my analogy to that is if I'm treating a hip, I need to make sure it's not coming from the back and it truly is coming from the hip. So making sure that you're getting a full picture of everything. Otherwise, you're going to be spinning your wheels and the patient isn't going to be getting exactly what they need to get the root of the problem.
Mm-hmm.
So in our last episode, we talked about biofeedback. Is there biofeedback for men as well?
Mm-hmm. Absolutely.
Can you tell me about that?
The same device that I would use for women, with the screen on my device that tells them what their muscle activity is doing in real time, or I can set it to different parameters to work on endurance or to work on power. Same thing that can be done for men. It's just a rectal probe instead of a vaginal probe. It's a little bit different. It's not so fun at first, but it can really help with body awareness. I even have fun games on my biofeedback device, like trying to catch the fish. And the guys think it's hilarious to go fishing, to squeeze and catch the fish and then relax and let the fish go. It's hilarious. But later I try to get them off the table and really work on applying what they've practiced with load, with push, with pull, because that's really when they're going to have issues with continence or pressure management or anything like that.
Are there specific exercises that you do to help strengthen that area?
Absolutely.
Besides the biofeedback and obviously besides doing a Kegel?
Yeah, well, I start with biofeedback really for re-education of like brain-body connection, to make sure that they know where those muscles are and how to activate them appropriately and how to relax them appropriately. If they need more relaxation and lengthening practice, I'm probably going to start with like pelvic opening stretches, like some of the yoga positions that might be common, like a butterfly position or a pigeon pose where you crisscross your leg in front and straighten the other leg out, and it's really intense. That's a great posterior pelvic opener. Some of the hip flexor openers can be very helpful as well, with deep breathing into that deep bowl of muscles that sits between your sitting bones. For the guys who really need more lifting power, I might have them work on quick flick movement, squeezing and lifting with a jump, with a push, with a pull, like with gravity helping at first, and then more in standing activities. If it's more endurance holds, I will do exactly that. Maybe we'll start with something like a bridge for a long endurance hold, coordinating their breathing and their deep core and their pelvic floor all together. And then I can start adding weight. We can do long endurance holds with a hip thrust and hold it at the top without losing it. We can work on standing overhead presses if that's something that they are struggling with, that pressure management or that leakage with such a long lever arm whenever they're lifting. When I say lever arm, I mean the weight kind of far away from your center of mass, and it becomes a lot more challenging that way. But as you've probably noticed, any exercise can be a core exercise if you think about it that way. It just depends more of what we're focused on, if we need to work on down training or upregulating and strengthening and lifting. But usually for example, my guys post-prostatectomy, I really need to work on power. They more so get their incontinence later on with like a cough or a sneeze or a jump or a push or a pull or jumping down out of the truck bed or running again or playing with their kids or their grandkids. It just depends.
Yeah.
Yeah.
So we've talked about the post-prostatectomy.
Mm-hmm.
We've talked about maybe even ED. You talked about a differential diagnosis where it could be coming from the back.
Right.
You like to do the mind-body connection for the neuromuscular re-education piece. Then we do some general strengthening with gravity probably minimized on your back or something.
Yeah.
And then working into more functional positions where they got to push or pull, squat or deadlift.
Right.
And then getting them back to their sport specific or vocation work specific type activities, or even recreational type activities around the house, pushing a lawnmower, stuff like that.
Absolutely.
Okay, so we've kind of gone down that. How long would a plan of care typically take for a male? Everybody's different, right? But again, it's not just a 1 week, 2 week type deal to get this thing corrected. How long is it typically for the male patient?
Similar to what I mentioned before, it could be 6 to 12 weeks, depending on what we're focused on. I mentioned earlier that the first really 4 to 6 weeks, you're getting a lot of neuromuscular adaptations happening, but it may not be true hypertrophy until a little bit after 6 weeks. When it comes to power, like single leg jumping over and over again, like our runners, or having to lift really heavy, that takes a little bit more time. It takes a lot of pelvic floor strength and hypertrophy to be able to do that. And type 2 muscle fibers, it's a lot of power in that range. Takes a little bit more time. But everybody's different and their goals are different. Usually for like post-prostatectomy, it's a good 12-week program. Slowly working against gravity, teaching them earlier on different techniques they can work on for fascia mobilization, all the way down through their pelvis and into their penis area and up into their abdomen where all their incisions are. Working on keeping their spine mobile and promoting blood flow to all of the healing tissues, and then starting to slowly progress with load. So it varies, but I'd say a good 6 to 12 weeks at least.
And this is all without medications, drugs, injections, unnecessary type of diagnostic studies that you can get somebody back to 100% or 110% and get them back to their normal everyday life.
Absolutely. Therapy is conservative.
That's it. That's right. Absolutely. Can you tell me about a success story that you've recently had with a male that has come into the clinic?
Yeah, I think one that comes to mind is one of the youngest patients I've had he had a radical prostatectomy for prostate cancer, and he was in his 40s. He's a dad, very active dad with kids playing sports. He coaches their teams. He works for one of the big delivery companies, so he's lifting boxes all day and driving around town all day. And he had high-level goals that he needed to work back to, including like returning to CrossFit and running and all his high-level activities. Aside from just not even getting to really grasp the fact that he had cancer and had to have such a surgery so soon, he was starting with like a catheter all the time, and it was very discouraging for him that he was leaking when he was previously 100% fine and had no trouble. So we had to like work a little bit on the mental health side of things, and I tried to get him referred to somebody who could help with mental health too, with counseling. And then I worked on scar mobilizations and manual therapy techniques to help with all that tightness and pain and sensitivity in the nervous system. We worked on relaxating fully so he could empty his bladder and not have leakage within 20 minutes after he just went, and helped him with emptying fully. And we worked on strengthening as well later with gravity assisted and then working against gravity, all the way up until we worked on power so he could run with load on his back or with weights in his arms while he's walking up a hill.
Sure.
And then he would, make jokes like, "Oh, I'm going to get chased by the dog at that one house and I got to sprint away quick."
Turn the treadmill up.
Yeah.
Speed it up.
We would work on power and sprinting even. It took some time, but he got everything back, all his goals. His intimate relationship improved as well because he finally got that blood flow back in that area, and that helped with his ED, and he's playing with his kids again, and it was really warming to see his success story as well.
Absolutely. I love hearing success stories in the PT world. That's great to hear. Again, a wealth of information. I appreciate your time out of clinic and coming down here and spreading the word to the community. And if anybody wants to get a hold of you, how do they get a hold of you?
We usually tell people to call our referrals coordinators at 423-777. Ooh, every time.
4974. I've
4974.
memorized it over the last 22 years. Or just ask Siri to call Summit Physical Therapy in Ottawa. 777-4974. Or go to summit-therapy.com and they can get set up for initial evaluation. I'm over at the Ottawa Clinic in Cambridge Square. One of my coworkers, Nicole, she's over at the North Shore Clinic.
She also treats pelvic floor. And we have a PT assistant in Saudi Daisy who also treats our patients as well.
Awesome. Well, again, I really appreciate your time. It's been amazing to learn about this essential part of physical therapy, and nothing but the best. So I really appreciate your time. Thank you.
Thank you, Kevin. And I hope any listeners out there who know of someone dealing with this silently and isn't open to talking about it yet, would start thinking about the fact that we can treat this kind of stuff, and they could go see their physical therapist locally to get some conservative treatment for things like this, and not to suffer anymore. Even though it's common, it's not normal.
Absolutely, yeah. Confront it and handle it. It makes it much easier on the therapy side to do it sooner rather than later. And I've been doing this for 22 years, maybe a little bit longer at this point, but that's what I've noticed over time is the sooner that I get you in, it's much easier to rehab you and get you back than somebody that's been dealing with it for stubborn 15, 20 years type deal.
Absolutely. So, just trying to spread the good word.
That's it. I love it. Well, thank you, Kelsey.
Thanks, Kevin.
All right.